Okay, good. Let me just get into presentation mode. There we go. So for those of you who can't see me, that's what I look like. Not that it matters much, but thank you very much for asking me to give this talk on living kidney donation from the patient or recipient's perspective. What I'm going to try and do during this talk is to illustrate the important role that living donation plays in kidney transplantation in Canada, to discuss some of the risks and benefits of living donor transplantation for the recipient. So I'm not going to talk at all about the risks or benefits from the donor perspective, nor am I going to talk about evaluating a donor. But what I will try and do is describe some of the key points that occur for a potential recipient as they explore the possibility of a living donor kidney transplant. So I'm going to start with this slide, and this is a rather sobering set of numbers. These are numbers taken from 2019. You'll notice that they're Canadian, but they do exclude Quebec for political reasons more than anything else, not my doing. I love Quebec, but unfortunately their numbers weren't available for this calendar year. So in 2019 in Canada, excluding Quebec, over 6,000 people developed end-stage kidney disease. Of those, 178, or 2.9%, received a kidney transplant as their first therapy. So they didn't start dialysis, they went straight to transplantation. The rest of those individuals started dialysis. And by the end of 2019 in Canada, there were over 23,000 people on dialysis, both hemodialysis and peritoneal dialysis. Of those 23,000 people, there were about 2,800 that were on a kidney transplant waiting list. And when I talk about the waiting list, what I'm really referring to is people on a list waiting for a kidney from someone who has died. Pretty typically in Canada, somewhere between 50 and 60% of people on a waiting list are actually on hold on that list, meaning they're not eligible to receive the very next kidney. They may be on hold because they've had interim medical issues. There may be reasons, infections or recent surgery that just means they're not in good enough shape to be transplanted right away, but they are still on the waiting list in the hopes that eventually they will be removed from hold, be active on the list, and get transplanted. During 2019, 60 people died on the kidney transplant waiting list. And during that year, we performed 934 deceased donor kidney transplants. So when one looks at the number of people who potentially would benefit from a kidney transplant versus the number of transplants actually performed for those people on the waiting list, it is pretty sobering. And I think this is unfortunately the reality, and this is what creates the waiting list. If we could manufacture kidneys and pull them off a shelf, there wouldn't be a waiting list. We would just do that as quickly as we could, and we would get people transplanted. But this is the reality, and it's the reality that is shared across the world in many countries. We do have another source of donor kidneys that we shouldn't forget about, and that's the living donor transplant. So this pink dotted line shows you the number of living donors over the previous decade from 2010 to 2019. You'll notice it's pretty flat. And when you consider population growth during this decade, the rate of living donation per population has actually declined slightly over this decade. In contrast, when you look at deceased donor activity, you can see some increase in activity. This is this top solid line with the open circles. Who are these people who donate living donor organs, both kidneys, liver, lungs, all possible? You might be surprised to know that about 57% of them are actually not even related to the recipient that they help. So the idea that you have to have a donor within your family is just wrong these days. You'll notice that over 60% are female, and that's true across all age groups groups. If you look at this table below, you can see various groups of donor age, and women are more frequently living donors than men. We could talk about why that is. You might want to ask me that question in the question and answer period. I'm not sure I have a great answer for it, but that is the reality. You'll also notice that not all of these living donors are young people. In fact, 16% of them are 60 years of age or older, and about 30% of them, or closer to 40% of them actually, are 50 years of age or older. So the idea that you have to be really young and healthy to be a living donor is not necessarily true. You do have to be healthy, but you don't necessarily have to be young. So this shows you the accumulation of transplant activity over the decade from 2010 to 2019. The darker blue bars are the deceased donor activity, and the aqua bars are the living donor activity. So currently in Canada, living donor kidney transplants make up about 1/3 of all kidney transplants that occur each year. So this is a very important source of donor organs, and it is one of those things that helps to keep in check somewhat the waiting list. If all of those individuals had to go on a waiting list, you can only imagine what that would do to waiting times. So what are the benefits of getting a living donor kidney transplant? The first benefit is the opportunity for a preemptive kidney transplant, meaning that you go from late stage kidney failure straight to transplantation without stopping on dialysis on the way. And as I showed, only about 3% of all individuals who reach end-stage renal failure in a given year have an opportunity of going straight to transplantation. But this is obviously a huge focus. We would like to see many more people go this route and reduce the strain that we all feel in our dialysis units. A living donor transplant is associated with a shorter duration of dialysis. So even if you miss the opportunity of going straight to transplant, you can greatly shorten your time on dialysis to transplantation if you have a living donor. This is Canadian data for the 3 years between 2017 and 2019. And you can see that the median duration of dialysis prior to a deceased donor kidney transplant was 1,362 days. In contrast, the duration of dialysis for those who got a living donor kidney transplant was 275 days, 1/5 of the time that it took for a deceased donor transplant. So that is also a huge benefit to individuals. It allows them to maintain better health as they're avoiding years and years of dialysis. It's definitely much less expensive to the healthcare system because dialysis is so expensive. It's also less expensive to the patient. There are a lot of hidden costs that the patients amongst you would recognize that dialysis patients incur. Simple things like driving to and from a dialysis unit. If you live an hour away from a unit and you're driving there 3 times a week, just think of the fuel bill that you've racked up. There may be childcare expenses and all sorts of other hidden costs that a patient and their family bears when they're on dialysis. And the hope is that transplantation would alleviate at least some of that burden. There's also better potential for matching, particularly if you have a related living donor, someone within your family who may share some degree of tissue antigens. And the more matching we can get, the lower the risk of rejection, perhaps the less immunosuppression or anti-rejection medication we need to use, and the better the outcome. And there's no doubt that living donor transplantation is associated with better both early and long-term outcomes. Early outcomes can be assessed by something simple. How many kidneys work right away when we transplant them? Well, for living donor transplants, 95% of them will work right away. For a deceased donor kidney transplant, that percentage that will work on average is about 80%, but depending on the donor type, the older deceased donor, or depending how the donor dies, we could have up to 40% of the kidneys or even more not working initially. They will eventually come around and work, but in the meantime, while we're waiting for that to happen, recipients do need to be on dialysis to support them. Probably most importantly, the long-term outcomes are also better with living donor transplantation. This shows you graft survival divided between a living donor in the dark blue and a recipient of a deceased donor kidney. You can see that at 1 year, there's not a huge difference in the outcomes. There's just a couple of percentage points. But when you start to extrapolate out to 5 years or 10 years, by the time you look at 10-year graft survival, what proportion of kidneys are still functioning at 10 years, there's a 14% difference in outcomes. And this just widens over time. So if you look at 15 or 20 years, it's even wider than that. So this is particularly important for our young people. If you're 20 years old, you may well need more than one kidney transplant during your lifetime. And the more we can have that first kidney function for as long as possible, the less likelihood you're going to need a second or a third transplant. So long-term outcomes are superior. For that reason, a living donor transplant is by far the best treatment for kidney failure. It translates into lower costs for the healthcare system and improved outcomes. Well, what are the risks of having a living donor kidney transplant? Obviously, the first risk is just the risk of having a transplant. And that's true whether you're getting a kidney from someone who dies or a kidney from someone who's alive. In many ways, the risks of the kidney transplant are actually lower with the living donor transplant because the kidneys often work right away. That keeps the hospital stay shorter. It alleviates some of the risk that you would need dialysis following the transplant. So although there is still the risk of the surgery versus remaining on dialysis for over the next week or month, these risks are actually lower if it's a living donor transplant versus a deceased donor transplant. I think the other set of risks that perhaps we don't totally appreciate is sort of the psychosocial risk to the patient. I think often patients are afraid of what's going to happen to their potential living donor. They're worried about the risk of putting a person that they care about who's volunteered to help them out of the goodness of their heart, and what the risk is that person's going to bear, both with the surgery itself, but also in the long term. I think patients can experience guilt if the donor experiences a complication. This is surgery, complications will happen. There's also guilt in a patient if the transplant fails, even if it's through no fault of their own. Just the fact that that kidney may not have lasted as long as one would have expected or hoped can create a lot of guilt that someone put their life at risk in order to give them that kidney. And in some cases, there's a sense of owing the donor something. This person has given this tremendous gift, but there can be this sense of obligation that as a recipient, maybe you need to do something as well for the donor. And for some people, that's a challenge to face. So how is the process of living donor transplantation started for the patient? The first step is the patient has to come to terms with the fact that they are reaching end-stage kidney failure. And for some people, that's a long process. You have to understand that transplantation might be a treatment option for you. It isn't for everyone. Not every person who starts dialysis is a transplant candidate. Once you realize that transplantation might be a treatment option, then you have to learn that some of these kidneys come from living donors, and maybe that's an option that you could explore. You then need to gather information from a variety of sources to try and decide learn what the process is, what the risks and the benefits are, what the options might be. You need to be referred and evaluated for transplantation. Just because you may have a very willing and potentially approved living donor, if you are not a candidate for a transplant, then that transplant is not going to happen. Many people will solicit advice from family and friends and even from other physicians who might be outside of a renal program or a transplant program. Just remember that that advice is not always well informed, and there's a lot of misinformation out there that may lead people to make decisions that perhaps in retrospect could have been different. So one of the huge barriers that programs face is this one, the barrier to the discussion around living donor kidney transplantation from a systems perspective. And there are many aspects to this that I can't spend time discussing individually. I think, first of all, in some programs, there's an absence of referral guidelines, like who is actually a candidate for a kidney transplant? Is this person I'm seeing in clinic who maybe is older, frailer, has diabetes, whatever, are they a candidate for a kidney transplant? Well, if you can't get past that, then you can't really have a discussion about what the donor source might be. There are healthcare attitudes. Some of us in the healthcare profession may feel that young people should really be directed toward living donor transplantation. But if you're dealing with someone of an older age group, maybe that's not such an important consideration, or maybe we shouldn't even be talking about it at all. So this is a huge problem. We have a lot of people working within renal programs, and many of them do not have a lot of training or access to information around transplantation. The wise will say they simply don't know and will refer patients to a better source of information. But sometimes people say things to patients that, quite frankly, are wrong. They're not done in a way that's meant to be harmful, but the net result is harmful. And it's difficult to educate all these people who are working in various roles through a large renal program. We also have the problem of lack of communication between various teams, between the CKD team, between the dialysis team, between the transplant team, and that can also cause delays or failure of a process to proceed. Then there's some confusion about whose job this really is. Whose job is it to help a patient learn about living donor transplantation? Is it the staff in the CKD clinic or in the dialysis unit? Or should they just stand away from that and it's entirely the transplant program's job to start those discussions? And that lack of a clear understanding of roles can really lead to substantial delays. I think there's also a lack of multidisciplinary involvement. Physicians are not very good at counseling. We often don't take the time it takes to really dive into something, to understand family dynamics, to help a patient work through some of those issues that might allow them to find a living donor. And then we have, going the wrong way. And then we have problems at the patient level that we need to overcome. Ultimately, it is up to the patient or their family to identify a potential living donor. And this is a huge issue for patients. There may be age-related reasons. I've had many elderly patients tell me, look, I've lived a good life. I couldn't possibly ask any of my children to donate a kidney to me. I'd be worried about what the risk would be. Maybe they need a kidney down the road. They need their kidney function. Maybe they'll develop kidney failure. There are cultural beliefs that affect individuals' willingness to discuss living donation with friends or family. There may be the size of the family and the social circle. If you're one of 9 kids and you've got nieces and nephews and aunts and uncles, and you may have a huge pool of potential living donors. If you're socially very active, you belong to community groups, the church, whatever, then you've got another whole community you can look at in terms of potential living donors. It's very helpful to have a patient advocate, but not everyone has that. Patient advocates can often take on the role of trying to find a living donor. So sometimes it's the spouse that spreads the word that their partner needs a kidney transplant and we're looking for living donors. And that can be very helpful because it's very hard for a patient to turn to someone and say, would you give me a kidney? Education is an issue. This is a complex area of medicine, and patients' understanding of their own health and the way systems work, healthcare systems work, can have a big impact on their ability to find a living donor. And there may be socioeconomic barriers. If you don't have a cell phone or a computer, you're not going to be on Facebook looking for a potential living donor. I'm not necessarily advocating that, but that is a way that some people do identify a potential living donor. If your partner is now the main wage earner in the family because you are on disability on dialysis, then it's very hard for that individual to necessarily take time off to be your living donor, even if they would be otherwise suitable. So there are many socioeconomic barriers. We do try and overcome some of those through reimbursement programs, but that doesn't mean that all costs are covered. Well, what about public solicitation? I've mentioned Facebook. So public solicitation is using the media or public search for a living donor. It's understood that the recipient needs to be a candidate for a kidney transplant. The donor must meet the usual acceptance criteria. Everyone should be aware it's illegal to buy, sell, or trade kidneys. And so anything that results in the trade of money or any other valuable consideration is illegal. And this can involve media releases, newsletters, billboards, community or workplace appeals, so within clubs or places of worship. It can involve websites. There's a notable one, matchingdonors.com, and social media such as Facebook can all play a role. I think there's sort of a bit of distaste around this whole area, and it does certainly raise numerous ethical issues. There's issues around equity. Is it sort of a beauty contest? The person who has the nicest website or the nicest Facebook page, who's perhaps the most attractive, who can write the best story. There's issues around accessibility. Not everyone has the technological resources to be able to be online and doing these things. There's issues around privacy. Once your information as a patient is out there, you can't control how it's going to be used. And that can have some negative consequences. There's also concern around the truthfulness of information. People are going to only portray themselves in the best possible light, both as a donor and a recipient. How accurate is the information that's being shared? There's issues around anonymity of the donor or the recipient. I think if we had our way, we would prefer that anyone who's answering a public appeal would not contact the patient, but rather contact the living donor so that the donor can remain anonymous to the recipient. But that donor knows who the recipient is that they're coming forward. So there is sort of a one-way risk there. We do see individuals come forward purely as a result of Facebook. They become Facebook friends. So they're not really anonymous living donors anymore. They're friends, just a different way of becoming a friend. And there is the potential for exploitation of the donor as well as the recipient that has to be considered. So most programs will consider publicly solicited donors, but I think there's an extra ethical obligation in looking at that. So how does the living donor process proceed? Well, you've got a donor and a recipient. They have their own teams. They're each going to be evaluated independently. The recipient may be approved, declined, or they may withdraw. They may decide transplantation is not for them. And the donor similarly could be declined, accepted, or withdraw from the process. If the recipient has an approved directed donor, meaning that donor is compatible with them and can donate straight to them, then surgery is scheduled. If, on the other hand, the recipient has a donor that is incompatible, then they would enter something called the kidney paired exchange program. So there are a couple of layers of incompatibility. The first big one is the blood group. You'll see from this table that we can't all receive kidneys from any blood group. If you are blood group AB, the rarest of blood groups, you can actually receive a kidney from every blood group. Everyone's compatible with you, at least from a blood group perspective. On the other hand, if you're blood group O, you can only get a kidney from someone who's blood group O. So a much narrower group of potential donors. And these blood groups are not distributed equally through the Canadian population. You'll notice that blood group A, 42%, and blood group O are the most common. Blood group B is about 9% of Canadians, and AB is a very rare blood group at only 3%. So if you were a type A patient looking for a living donor, you can get a kidney from someone who's blood group A or blood group O. Well, that's almost 90% of the Canadian population. So obviously your donor options are much bigger than someone who's blood group O and can only receive from blood group O. So that's a huge compatibility barrier in some cases. The other barrier is the immunologic barrier that sometimes people through blood transfusions or pregnancies or previous transplants actually develop antibodies against the tissue markers. And that means that future donors that share some of those same markers may no longer be compatible for that individual. There are also some incompatibilities you might not necessarily think about. So what about a child whose only living donor is a 70-year-old grandparent or a great-grandparent? Is that the best kidney for that child? Maybe one would want to try and find a different donor through this kidney paired donation program. And the same with size mismatching, where maybe you have a very large recipient and their only living donor is a small individual, often female. Maybe it's not enough kidney for that particular person. So there are a variety of reasons why people may choose to go into this paired exchange program. This is basically a donor swapping program. It was established in Canada in 2009. It's a national program, so it has advantage of numbers. And patients can go into this program with one or more approved but incompatible donors. And what we try and do is we identify ways in which donors can be swapped between pairs. Many of these include blood group O recipients because of that blood group disadvantage. Match runs are conducted every 4 months, and you can see the numbers over the first decade of activity. Over 1,000 people participated on the recipient and donor side. There were 146 non-directed anonymous donors. I'm going to come back to that because that's really important in the success of this program. And in the first decade, over 660 transplants were performed. 550 went to patients who brought a donor into the system, but you'll notice 113 went to waitlisted patients. Well, how did they get involved in this? And they get involved through what's called a domino chain. This is the simplest kind of paired exchange. You have two pairs, their donors are incompatible with the recipient that they want to help. And so those kidneys are simply swapped. Donor A will give to recipient B, the pair B, and that person's donor will give to the recipient of the pair A. So that's a simple two-way swap. Now it can get more complicated. This is a three-way swap, but it could be a seven-way swap where the donor in pair A gives to a recipient in pair B, the donor in pair B gives to the recipient in pair C, the donor of pair C gives to, and on it goes. And at the very end, there's a kidney that comes out from the very last donor that goes back to the recipient in the pair that started the chain. This is a closed chain and it can have 6, 7 pairs, potentially more. It's just the logistics get very challenging. But the really important chains are what are called the domino chains. And a domino chain involves a non-directed anonymous donor. You can think of this person like a blood donor. They show up at Canadian Blood Services, they give a unit of blood. They have no idea where that unit of blood is going to. They just know they've helped someone who needs a unit of blood. A non-directed anonymous donor is the same. They've heard about long waiting times. They have this great desire to help. And so they come forward. They don't know anyone who needs a kidney, but they would still like to be able to donate a kidney to someone in need. And we encourage these individuals to participate in the paired exchange program. And you'll notice that the other important person that participates in this is a patient on the wait list. So what happens here is that you have this non-directed donor who donates to recipient A. That person's donor donates to recipient B, and donor B donates, and on it goes. And at the very end, there's a donor kidney in the very last pair that comes out, and it actually goes to someone on the waiting list. So this anonymous donor could have donated directly to this person on the wait list, but by participating in the paired exchange program, they've actually helped create a chain of kidney transplants, as well as getting the person on the wait list transplanted. So this is a critical piece of the success of the paired exchange program. And you can see in this solid line that the percentage of kidney transplants done through the paired exchange program in any given year, between 40, 60, 65% of them are created through those anonymous donors who participate in KPD. The other thing, just a bit of good news that's happened with the pandemic. There's so few good things with this pandemic, but the one good thing is it has broken the deadlock on shipping living donor kidneys. This is something that had been done in other paired exchange programs around the world, but the Canadian program had been very slow to adopt the idea of shipping living donor kidneys. But because of all the restrictions with the pandemic, the cat has been let out of the bag and there's no bringing it back. And so now we are starting to ship living donor kidneys as part of the paired exchange. And that's obviously so much easier for the donors that participate in this program, that they can get their surgery close to home, often where the recipient is getting their surgery, and they're not having to travel and incur costs that some of which cannot be reimbursed. So this has been a good news story from the pandemic. So what I've tried to do in this talk is to discuss the important role that living donor transplantation plays in the overall transplant activity, to review some of the risks and benefits of going forward with a living donor transplant, and to describe the process that allows this to happen with a few key issues around how to find a living donor and the paired exchange program. And so with that, I'd be happy to close. I would just say that the September patient forum, I'm going to be giving a talk on living donor transplantation from the donor's perspective. So you can stay tuned for that if you're interested.